My name is Niall Gallagher and I am a social worker within the Community Specialist Palliative Care team in the Southern Health and Social Care Trust. I want to talk about palliative care and what that means for staff. The aim of this presentation is to give an overview and understanding of palliative care. The who, what, where, why, when and how of palliative care. What is palliative care? Why is it important? Who is it for and who delivers it? When is it used? How can I do it? Where is it delivered? What is palliative care? Palliative care is treatment, care and support for people with a life-limiting illness and their family and friends. It's sometimes called supportive care. The aim of palliative care is to help the patient to have good quality of life. This includes being as well and active as possible in the time you have left. It can involve managing physical symptoms such as pain, emotional, spiritual and psychological support, social care, including help with things like washing, dressing or eating, support for family, carers and friends, end-of-life care and bereavement support. Palliative care aims to reduce unwanted, unnecessary and painful treatments or interventions. Palliative care can improve the person's response to treatments. It can increase the ability of people's family to cope with and care for a loved one. It can improve patient and family satisfaction with care. It can also help patient and family come to terms with the situation. Who is palliative care for? Palliative care can be used for people living with many conditions. For example, cancer, cardiac disease such as congestive heart failure, COPD, kidney failure, Alzheimer's, Parkinson's, and many others. Palliative care can also have an important role in the care of people who are acutely unwell and unlikely to survive. Who provides palliative care? Multidisciplinary teams involving both generalist and specialist health and social care professionals and support staff. It's a responsibility of all health and social care staff regardless of care setting. Family, carers and community provide palliative care. As we can see in the slide, general palliative care involves multiple professionals. As we can see, that includes GPs, allied health professionals, Marie Curie nurses, Macmillan nurses, social workers, domiciliary home workers, district nurses, healthcare assistants, ward nurses, nurses in private nursing homes. A referral to the specialist palliative care team should be considered for those patients and families with complex needs which cannot be resolved following intervention from core services. The team includes a social worker, pharmacy, occupational therapy, physiotherapy, speech and language therapists, dietitians, clinical nurse specialists, specialist palliative care practice facilitators, and palliative medicine consultants. When should someone access palliative care? Palliative care is appropriate at any stage of a serious illness, and ideally is introduced early in the treatment course. Research has shown the longer someone is exposed to palliative care, the greater the likelihood they will experience greater quality of life in the final stages of their illness. Where can we get palliative care? Palliative care can be at home. It can be in hospital. It can be in the hospice. Palliative care can also be in a care home, a residential home or a nursing home. How do we do palliative care? The basis of palliative care is compassion. Know that your kindness and compassion makes a big difference to patients and their loved ones. Simple kindnesses can help to diffuse negative emotions that are associated with cancer diagnosis and treatment, and may even help to improve patients' outcomes. How patients and families cope with serious illness and dying. People cope. People go through a range of emotions, from disbelief, guilt, despair, shock, fear, depression, denial, anxiety, acceptance, anger, even resignation. Just to go through a few of these emotions. Disbelief. Expressions of disbelief are common, and an acknowledgement of how hard it is for the patient and family to absorb the situation is appropriate. Shock. The result of being emotionally overloaded or overwhelmed, unable to function normally. Denial. A person is unable to admit to others or themselves that they or a loved one have a serious illness and that death is imminent. Anger. Many dying patients and their families experience anger, which can be accompanied by blame. It may be directed at the world in general or God, anyone trying to help. It can be inward. It can be directed at relatives and friends. As anger is frequently directed at those who are physically and emotionally closest to the dying person or carer, it is often very painful to deal with. Guilt. Guilt can be experienced by people who feel that their situation or their relative may have been preventable. People can also feel guilty about the burden they are placing on carers and family. Fear. Fear includes those of pain, the treatment process, dying and death. Dying people fear losing control over their lives. Anxiety. Dying people may experience anxiety because they are separated from their families or in unfamiliar surroundings. Despair and depression. Dying people and their families frequently experience despair. Despair equates with loss of hope. Depression may be an appropriate response to the knowledge that one is dying or someone they love is dying. Acceptance and resignation. People may move towards recognition that they or their relative is dying. It is important to remember that patients or their families may be experiencing any one or a combination of these emotions at any particular time, and therefore their behaviour may not be as you would normally expect. So what makes talking to patients and their families about death and dying difficult? Sometimes it's difficult to determine if it's the right time and place to discuss. Do the patient family want to talk? Maybe you've lack of communication skills, lack the confidence to discuss difficult issues, you don't know what to say. Fear of causing distress to the patient or the family. Maybe fear of expressing your own emotions. Fear of being blamed. Some of the reasons why we get stressed. Maybe it's facing our own mortality, facing our limitations, personally and professionally. Learning to be with patients rather than doing things for them. Maybe we try to solve everybody's problems. Remember, the family is not ours. Taking difficult issues home. How can you help? Communication skills are vital in palliative care. Often it is not what you say, but how you say it. It has the most impact. Be clear when you communicate and check to establish their interpretation. What can you do if the patient or family get upset? Ask them how they are. You might have no answers, but you have given them the opportunity to talk. Acknowledge that they are upset. For example, I can see that you're upset. Make contact through touch. Example, a hand lightly on an arm. Stay silent for a while. Ask if they want to continue or do they need a break. This allows the patient or family member to be in control. Again, communication is vitally important. Good use of body language. Body language is a term used for communication, using body movements or gestures instead of or in addition to sounds, verbal language or other communication. Positive body language shows that you are interested in what the person is saying. Assure the person that they are doing everything possible for their loved one, as many feel helpless at this time. Involve the family in the patient's care. Encourage the family to talk to the patient. Talk normally as a family in the patient's presence. Tell the person about everyday happenings. Avoid clichés or platitudes, saying things like, "Everything happens for a reason, and it's God's will." This can make the person feel like their illness is their fault. Saying things like, "You're strong and you'll get through this," is equally problematic. Have the conversation about end-of-life care. We call this advanced care planning. Advanced care planning is the term used to describe the conversation between people, their families, and carers and those looking after them about their future wishes and priorities for care. Advanced care planning is a key means of improving care for people nearing the end of life and of enabling better planning and provision of care to help them live well and die well in the place and the manner of their choosing. It enables people to discuss and record their future health and care wishes, and also to appoint someone as an advocate or surrogate, thus making the likelihood of these wishes being known and respected at the end of their life. The main goal is to clarify people's wishes, needs and preferences and deliver care to meet these needs. Advanced care planning is a way to think ahead, to describe what's important to you and to ensure other people know your wishes for the future. It's about helping you to live well right to the end of your life. Thinking ahead, discussing with others and writing things down means that your wishes are known and respected, and you're more likely to receive the kind of care you want in the place you choose if you become unwell or if you can no longer speak for yourself. The Trust has a booklet called Your Life and Your Choices Plan Ahead, which has copies of advanced care planning within them. These are useful to give to families. Helping ourselves. It is important to help ourselves when working in palliative care. To do that, by reflecting on the experience, we can ask ourselves, how did we cope? Was there anything we could have done differently? Are there things we could improve on? Are there things we did well and can bring back to other team members? Discuss with your colleagues. Use supervision. Maybe you need closure. If appropriate, you can attend a wake, funeral, send a card. Use support mechanisms for staff if you need to. Use your colleagues, fellow colleagues, a supervisor, other staff involved in the patient's care. For example, the GP, the district nurse, specialist palliative care team. Use the Trust SharePoint in the Southern Health and Social Care Trust under staff health and wellbeing. Maybe use specialist help, for example occupational health, care call, bereavement counselling. Look after yourself, lower your stress, use a healthy diet, exercise, hobbies, relaxation. So, what does a palliative care approach look like? This table shows the process. It aims to provide effective symptom control and management. It provides open, sensitive communication with the person, family and colleagues. It's a holistic approach, including life experiences and the current situation. It's concerned with promoting the quality of life. It's about care for a dying person and those who matter to them, as well as bereavement support. Though no one can go back and make a brand new start, anyone can start from now and make a brand new ending.